Alright, continuation of hemodynamic disorders. So far we have discussed about edema, hyperemia and congestion. So moving on to the next topic, hemorrhage. Hemorrhage means extravasation of blood into extravascular space. So whenever there is damage to the blood vessels, so there may be leakage of blood into extravascular space, and then you simply call it as hemorrhage. So if it is external, so coming out of the body, so you call it as external hemorrhage. Or if the blood is getting accumulated within a tissue inside the body itself, then you call it as hematoma. So hematoma is nothing but internal hemorrhage. And then we have got various causes for hemorrhage. So chronic congestion, so which we have discussed before. So chronic congestion is seen with increased hydrostatic pressure. So where small capillaries which cannot withstand may undergo rupture leading to hemorrhage. And then we have various bleeding disorders. All of them are included under hemorrhagic diathesis, so like hemophilias. And then trauma to the blood vessels. So in any form, so the vascular injury results in hemorrhage, and it can be even seen in association with inflammation or tumors. So inflammation causes damage to the blood vessels, and also tumors, especially malignant tumors, can even cause damage to the blood vessels. In all these cases, they end up with having extravasation of blood causing hemorrhage. Then, depending upon the size of hemorrhage, we have petechiae, purpura, and ecchymosis. So, petechiae are the smallest hemorrhages, so which are of 1 to 2 mm in size, and purpura are slightly larger than petechiae, so they are of 3 mm or more than 3 mm in size, and largest hemorrhages are ecchymosis, which are known as bruises. So, they are more than 1 to 2 centimeter in size. So as a whole, we have petechiae, purpura, and ecchymosis. Smallest are petechiae, which are considered as pinpoint hemorrhages. And then coming to the clinical applications, so with massive loss of blood, patient may even go into the shock, so which is called as hypovolemic shock. And minute volume of blood is being lost over a period of time, so which is chronic blood loss. It may eventually end up in iron deficiency anemia, and hemorrhage may lead to jaundice. So because of lysis of the extravasated RBCs, there may be increased bile pigments being formed leading to jaundice, and sometimes with excessive loss of blood it may even lead to death of the individual. And with the accumulation of blood within the body cavities, so we have different terms here. So with accumulation of blood within the pleural cavity, hemothorax, within the pericardial cavity, hemopericardium, within the peritoneal cavity, hemoperitoneum, and within the joints we have hemarthrosis. So in the first picture you can clearly see pinpoint hemorrhages which are of small size, so they are known as petechiae. And from the second picture you can see large hemorrhage, so which is nothing but a bruise or ecchymosis. Then moving on to the next topic, so that's thrombosis. So thrombosis is actually a state of having thrombus within the circulation, and thrombus is nothing but an intravascular solid mass attached to the underlying blood vessel wall. So the two rules are thrombus is always a solid mass, and it is always seen attached to the underlying blood vessel wall, and it is seen formed from the circulatory elements within the circulation. So an intravascular solid mass attached to the underlying blood vessel wall. And we have different types of thrombi based upon their location. So if thrombi are seen localized to the cardiac chambers or to the great vessels like aorta, you call them as mural thrombi. And if there are thrombi formed on the heart walls, we call them as vegetations. And then there is a different term which is known as clot. So even though we use these terms interchangeably, but they are two different terms. So remember, clot can be either intravascular or extravascular, but thrombus is always intravascular, and clot is free in the circulation, but thrombus is always having an attachment to the underlying blood vessel wall. And in the formation of clot, platelets are not involved, but in the formation of thrombus, platelets are always involved. So the first picture shows the thrombi which are taken out from the blood vessels, and then the second picture shows the thrombus which is seen attached to the underlying blood vessel wall. So it is not free in the circulation. Then coming to the formation of thrombus, we have Virchow triad, so which is formed with the three important elements. So the first one and the most important one is endothelial injury, and the second one is hypercoagulability, and the third one is abnormal blood flow. So from the picture you can clearly say endothelial injury can lead to hypercoagulability, and also endothelial injury can lead to abnormal blood flow. And abnormal blood flow can lead to hypercoagulability, and also it can lead to endothelial injury. So all these three factors can act independently leading to thrombosis, or they can influence one another leading to thrombus formation. So among them, definitely the most important one is endothelial injury. So endothelial injury is seen in association with various factors, and this endothelial injury is seen in two different forms. So there may be endothelial activation or dysfunction, or there may be frank endothelial damage. Endothelial activation or dysfunction is seen in association with hypertension, smoking, hypercholesterolemia, or homocystinemia. So where endothelial function is being altered so that the thrombogenic property of the endothelium is aggravated. And whenever there is frank endothelial damage, so which can be seen in association with myocardial infarction, atherosclerosis, or vascular injury, definitely that leads to thrombus formation. And then alteration in blood flow. So alteration in blood flow is seen in two different forms. So one is stasis and another one is turbulence. So either stasis or turbulence, so alteration results in disruption of the normal laminar flow. So whenever there is disruption of the normal laminar flow, it promotes endothelial activation. So endothelial activation increases thrombogenic properties. So stasis can be seen in association with aneurysms and hyperviscosity or sickle cell disease. And turbulence is usually seen in association with atherosclerosis. And coming to the third factor, that is hypercoagulability, which can even known as thrombophilia. So hypercoagulability can be either primary or secondary. So primary is genetic. So the two important factors of the clotting cascade is seen being mutated. So the first one is factor 5. So factor 5 mutation is also known as factor 5 lead-in. And the second factor is prothrombin, so which upon mutation, so it also can lead to hypercoagulability. So whenever there is mutation involving factor 5 or prothrombin, it leads to hypercoagulability. And then secondary, so which is acquired, so it can be seen in association with various factors like immobilization, myocardial infarction, cancer, tissue injury, antiphospholipid antibody syndrome. And then depending upon the vasculature being affected with the thrombus, so we have arterial thrombosis if arterial circulation is involved, and we have venous thrombosis if venous circulation is involved. So venous thrombosis is also known as phlebothrombosis. So arterial thrombosis is usually seen in association with the two important factors from the Virchow triad. So one is endothelial damage and second one is turbulence. And on the contrary, venous thrombosis is seen in association with the rest of the factors like stasis and hypercoagulability. Arterial thrombosis usually appears pale and venous thrombosis usually appears dark red, so because of more RBCs taking part. And the most common sites for arterial thrombus formation are coronary artery, the most important one, and that is followed by cerebral artery and femoral artery. And for venous thrombosis, So veins of the lower limb are the most important site. And arterial thrombosis, as you know, arterial circulation is active flow. So arterial thrombosis is usually formed in active flow, and venous circulation is less active in nature. So that's why venous thrombus is usually formed in less active flow. And arterial thrombus can be either occlusive or not occlusive. So like if the thrombus is formed in cardiac chambers or in great vessels, so it may not be occlusive. But venous thrombus is almost always occlusive in nature. And coming to the composition, in case of arterial thrombosis, so as the circulation is active in nature, so there will be less chances for more number of RBCs to get entrapped. So RBC count will be less, but platelet count will be more. So this makes the arterial thrombus look pale. But in case of venous thrombus, so as it is formed within the less active flow, so there is greater possibility for more number of RBCs getting entrapped. So that's why more RBCs, and platelets will be less. So that makes the thrombus look like dark red. So the first picture shows presence of the thrombus involving coronary artery. So that is an arterial thrombus. And so coming to the second picture, so if you open up the blood vessel, you can clearly see a thrombus being formed. Next, coming to the complications, so whenever there is a thrombus, which is nothing but a solid mass occluding the blood vessel, causing an obstruction to the circulation of blood, so definitely, so the complications are obstruction, and also that is followed by embolization. So once the thrombus gets free in the circulation, so when you call it as embolization. And coming to the fate of the thrombus, so the thrombus can be seen with the propagation. So propagation indicates there is increase in the size of the thrombus with more recruitment of cells, be it platelets or RBCs. So it keeps on increasing in size, which is known as propagation. And then once thrombus gets detached from its underlying attachment, so it is free in the circulation, then you call it as embolus. So where you call it as embolization. And we have fibrinolytic mechanisms coming into role following formation of thrombus. So these fibrinolytic mechanisms cause degradation of the thrombus, so leading to disappearance of thrombus, so where you call it as dissolution. And then finally, there may be organization and recanalization. So organization means getting stabilized. So once there is ingrowth of the fibroblasts and the deposition of connective tissue, the thrombus gets stabilized. So then you call it as organized thrombus. Or there may be formation of small blood vessels within the thrombus itself, and these small blood vessels may restore the blood supply prior to the obstruction and to the post to the obstruction. So this is what we call as recanalization. And then a brief note regarding postmortem clot. So postmortem clot usually gelatinous in nature, unlike normal thrombus, which is usually firm. And postmortem clot, just like any other clot, it is having no attachment to the underlying blood vessel wall. So no attachment. And then postmortem clot is usually having two different portions. So the upper portion and lower portion. So the upper portion, which is composed of plasma, it appears yellowish, so known as chicken fat portion. And the lower portion, because of sedimentation of RBCs, it appears dark red. And there are no lines of John when it comes to the postmortem clot. So with the lines of John, we'll get to know at the time of autopsy whether thrombus is antemortem or postmortem. So lines of John are nothing but bands which are seen in association with pale platelets and fibrin deposits, alternating with darker red cell rich areas. So we have pale bands alternated with dark bands. So that gives you a laminated appearance. So this is what are called as lines of John, and this is a property of antemortem thrombus. So postmortem clot is not seen in association with lines of John. So the first picture shows clearly, so you have pale bands alternating with dark color bands. So pale bands, they are composed of fibrin and platelets, and the darker bands are composed of RBCs. So these are known as lines of John. So a property of antemortem thrombus. The second picture shows postmortem clot where the upper portion appears yellowish, so yellow chicken fat portion composed of plasma, and the lower portion appears dark red, which is seen with RBCs.